good day, depending on when you're joining us or where you're joining us from. My name is Sabrina Hansen, and I am the Director of Professional Relations here in the DC metro area, is where I'm at in this virtual space. And I'm with Embark Behavioral Health. So you are here because you would like to learn more about short-term treatments for long-term impacts. And so we are having a panel discussion to talk about these things. So I will go ahead now and I would like to introduce our amazing panelists. And so I will start off with Helene Creasy. And Helene, if you want to say hello, just so that people can see your lovely face on speaker mode, that would be great.
Hello, can you hear me?
We can hear you.
Awesome.
So Helene is our VP in our Philly metro area programs. She is a licensed clinical social worker with over 30 years of experience developing programming in various adult and adolescent treatment settings, including inpatient care, PHP, IOP, and outpatient care. Next, we have Dr. Cassandra Sims. Dr. Cassandra, welcome.
Hello.
So Dr. Sims is a board certified psychiatrist supporting both adults and child and adolescents. And she serves as the Psychiatric Service Director for students at Embark at the Forge. And Embark at the Forge is a short-term residential treatment program for teen boys with teen mental health concerns. And it is located in Benton, Tennessee. I think they have snow out there right now. And she's been supporting clients for 17 plus years throughout the continuum of care and has also found a passion for teaching students through her clinical experience. And she's a faculty member with the University of Tennessee School of Medicine. Thank you again, Dr. Sims, for being on. Next, I will be introducing Dawn Halliburton Rudy. Good morning, Dawn.
Morning and afternoon, everyone.
Dawn is the executive director of Embark at Campbell in Northern California, and she is a licensed clinical social worker with 20 plus years of experience holding 3 degrees related to the field of psychology. Now, I'm going to get this piece wrong because I've been practicing how I'm going to say it, but it's amazing. So she is an expert in multimodal psychotherapeutic applications. I did it. And trainings, as well as leadership, team development, innovative problem solving, management, program, and strategic development. Thank you so much, Dawn. Finally, we have Matthew Dale. Matthew, welcome. Thanks for being here.
Good morning, good afternoon, everybody.
Matthew is our executive director of Embark at Mainline, which is located in Berwyn, Pennsylvania, and he has over 20 plus years of experience and has really dedicated his life to the behavioral health field. He served in multiple capacities as a clinician, as well as an operational director in both inpatient and outpatient levels of care. So again, thank you so much for being here and for representing Embark on this panel. So I cannot, while we have these incredible team members, these 4 that you see on the panel, the work that we are doing would not be possible, honestly, without our entire team. And I see many other Embark faces and Embark family members on this call. So at this time, I would love for any Embark staff member to maybe add an emoji or put a comment in the chat, say hello. Really just want to say thank you for all that you do, because again, while we're highlighting these 4 incredible individuals on our panel, it's a team effort every day to support families and our students. So thank you so much. Love it. Okay. All right, so I am almost done with my intro, I promise. So we are now going to segue into the official part of the panel. So again, we are here focused on short-term treatments for long-term interventions. And I think we all know that many times long-term private pay treatment programs are really out of reach for families. that really might need those services. And at Embark Behavioral Health, we now offer short-term options that work with third-party payers as an alternative to these long-term private pay solutions. So at a time when the levels of adolescent anxiety and depression and suicide are at these all-time highs, having access to quality treatment really is vital. So we are all here today as a supportive, collective community to explore how short-term programs operate, investigate their efficacy, and to learn how they fit into the continuum of care for families that are struggling and suffering. So with that in mind, we are going to turn the time over and I will show you a brief testimonial from a parent to really set the stage for our discussion. So you will see that in just a moment.
My child is adopted, an older adoption child, and it was really difficult to find a place that we felt would make him feel loved and also be able to support him for his needs. I felt Embark in general, that whole, if you look online, there aren't any really bad reviews at any of their residential treatment centers across the US. And it gave me a lot of, to know that this was probably a better place. This place offered so much, and the beautiful outdoors and cutting edge psychology and psychiatry that was above and beyond what else I could find.
Of course, people get paid to work here, but it didn't seem like they were here for a paycheck. It didn't seem like they were here to be babysitters. It seemed like the people who were here were actually here to help. And they modeled behaviors that my son could emulate. They modeled behaviors even when things got to be difficult. And when there were some challenges, they were consistent. And so they actually taught him to be consistent, and they taught him to model some of these same behaviors. So when he encountered situations, he was able to react in a way that he was not able to react before. People described him as a calming influence, which was incredible to me because he was not when he came here. One of the things that we tried to teach him at home, but we were not successful with, is not to sweat the small stuff. And the small stuff would trigger him sometimes. And there were a couple of things that happened here where he reacted in a way that it seems like he's actually learned that lesson. He understands that, at least he understands now, that everything is not a crisis. And sometimes we can avoid crisis by not making crises ourselves. And I think that's one of the most important things that he's learned here. And that was really key and will be key in his emotional and social growth as a human being.
I know that he's made so much progress here. I can tell by our weekly calls, I can tell from talking to his therapist, he is ready to come home and he's completed the program, and I could not be happier that this was the place that I chose for him. We hail from out of state, and I remember going home, I was like, I left my child in Tennessee, and I was nerve-wracked, but coming to get him today, I knew everything was going to be fine, and I knew that everyone would be welcoming, and it was everything that I expected. And of course, we're thrilled to have him back and know how much help he's had, and hope that we can do a great job when we get home. They've prepared us, so we hope that we'll be ready.
When he first came here, again, he faced some challenges, and we're really excited that he's learned a lot and has faced some of his challenges and has much better coping mechanisms. And this will help him through all facets of life. I think that being here, he's actually going to have a leg up on some of his peers because he's learned some things that I believe a lot of people don't learn until they're much older in life by being here. And I'm very excited to see how he's going to do on his journey going forward.
All right. Okay, so now that we are all back together, we're going to have some fun. I'm going to launch a poll question. So just two of them. So you're going to see a question show up, like a game show you didn't think you were going to be on? What topics are you most excited to hear about in this panel? Clinical interventions, education, continuum of care, outcomes. What will it be? 10 seconds left. All right, I think I see a winner. It's actually kind of close. I'm going to end the poll. All right, I'm going to share the results. It looks like the majority of people are interested in the continuum of care options, followed by clinical interventions and outcomes. So thank you for that. I'm going to launch one more. All righty. Okay. How familiar are you with short-term residential treatment programs and the type of support they provide? Very familiar, somewhat familiar, or not familiar at all. This one's not jumping as much on my end. Okay. 5 seconds. 4, 3, 2, 1. Ending the poll. All right. It looks like many of you are somewhat familiar. So fantastic. And some are very familiar and some not familiar. So we've got a pretty good range. And so hoping, actually, can you see the results? There you go. So hopefully that you will take some stuff out of this panel. We are very, again, excited for you to be here. So I hope that the poll is not in your face anymore. All right. So again, we are here because there is a huge dilemma. And really, as many of us know, intervening to help youth dealing with critical mental health issues is really determining when to abandon the family-centered, community-based therapy and place a young person in a residential treatment program or another type of supportive service that might be away from the home. So I'm going to use Helene to help me answer this first question. So can you help us understand really what is a short-term residential treatment program?
Sure. So short-term residential treatment is generally we look to have our families and our kids enroll for anywhere from a 60 to a 90-day treatment process. We provide a really intense approach involving psychiatric care, therapist care, experiential, recreational opportunities. We support them through their education process. And the goal really in a short-term model is to provide a really intense, structured environment where we get to know the student, their family, and really set them up for success so that as they move along the continuum of care after us, we have a great understanding of what their needs are, support the family, and then help get them set up for the continued care after they leave us.
Great. Thank you so much. That was a wonderful overview. To piggyback on that, when would you say, and I'll use Dr. Sims if you can respond to this question, when would a referral to a residential treatment be therapeutically appropriate for a client and medically necessary?
Of course, as providers, we want to be able to take everyone, but unfortunately, there's processes in place that kind of limit that ability. And so in providing care, most commonly individuals that are more appropriate and easily approved by our insurance companies are those that have an outpatient psychiatrist and outpatient therapist in which they've regularly attended consistently, or even showing non-compliance because it's still showing a failure in that form of care. In general, there's some form of hospitalization, acute hospitalization, 2 or more hospitalizations in 6 to 12 months, maybe some before that, but at least showing that that is a process that's in the community that has failed and they're still exhibiting its difficulties. Possible failure in IOP, PHP, or in-home services. Some kids, before they've come to us, have at least attempted that. So any of those combinations sometimes leads the insurances to see our kid is not able to function in our community, so we need a higher level of care to kind of get them more stable. In that case, then you go to an area of medical necessity. For our kids, when they show impairment in their functioning and their social impairment and functioning of the social environments, such as their home and their friend peer life, occupational functioning, behavioral functioning. When there's an impairment of that, that's showing that what we're providing for them in the community is not working. And then you go up a level when they may have suicidal thoughts, homicidal thoughts, or psychosis. They've had a trend of that that's kind of been there. That ups the level of intensity. Of course, if it's one that's actively psychotic or suicidal, that may go to an acute hospitalization situation. But if it's a pattern that's somewhat stable, that bumps the medical necessity up, which would supports the need for a longer term, short-term residential program to provide stabilization.
Thank you so much, Dr. Sims, really painting a picture as well on like what the ideal client is and really when a referral to this level of care is appropriate. So again, I said that this was going to be an interactive discussion. If anyone needs more clarity or wants more information, feel free to start writing some questions in the chat. Again, this is going to be very high level information, but we can get much more granular. So certainly feel empowered to do that. So moving right along, I don't know why I keep getting muted. So thank you all for being patient with me. So research really does show that residential treatment is best when it involves the family in the treatment process and when it promotes collaboration with the community in the discharge process as well, and is shorter in duration. So again, Dr. Sims, I would love to have you answer this question. Can you share with us how we incorporate the family in our treatment approach as it pertains to short-term residential treatment specifically?
Incorporating the family, it really starts from day one. It starts from the pre-screen, phone screen, all the way to the discharge situation, because that's where you develop your rapport. These parents are in desperate need of stabilization for their children. And so in going through this process, outpatient communities are always being accused of not being good listeners. So being able to represent to our families that we're here to listen and to provide sets up an immediate rapport for them individuals. So in understanding the family systems of our families that we encounter, that allows us to emulate that in our program, because I think what our program should also do is in the family atmosphere, but also in that family atmosphere, model the type of consistent boundaries and communication that we want our families to also emulate. And also emulate that we're going to listen to the child, but also help them communicate that with their families. So involving them from the day one step all the way to the end, as well as involving them with the outcomes, the questionnaires that we do, so we can see what progress they see along the line of their progress in treatment, and see how aligned that is with the child, as also how aligned that is with what we're seeing in the facility.
Wonderful. Thank you so much again, Dr. Sims. So I am going to take a little pause and we're going to do another poll as we transition to talking a little bit about IOP and PHP, and then we'll kind of do a ping pong back and forth to different parts of the continuum. So I'm going to go ahead and launch this question. How familiar are you with PHP, IOP, and the type of support they provide? So PHP would be partial hospitalization program, and IOP would be intensive outpatient program. And I am going to end this poll in about 3 seconds. Click, click, click. All right, I'm going to end the poll. I'm sharing the results. Wow, 42 and 42, very familiar and somewhat familiar. A tie there. And then there's 15% not familiar. Thank you so much for participating in that. So with that being said, once a client, say perhaps graduates from a short-term residential treatment program, or maybe if a client happens to need just a lower level of care in general coming straight from the community, how can we provide additional structure and stabilization throughout the continuum? So I'm going to pose this question to Matt. If you don't mind kind of describing the structure and stabilization portion in the IOP PHP setting.
Sure. Thanks, Sabrina. So the clinics are designed to be a gateway to access treatment for the families. It can be used as both a step into treatment and a step down. We like to kind of meet families where they're at. So when they call and they're inquiring about care, we have a variety of options from assessment to outpatient medication management, IOP, and PHP that we can use to bring a family into the system to help support them. Sometimes families do go directly to residential care. And if they do so, then the IOP and the PHP program is used as a transition step down. So utilizing the same treatment modalities that we're using in our residential programs, we continue to follow the family at each step of the way. Our PHP program meets 5 times a week, 6 hours a day, and is designed with the same rigorous programming in a residential program, but the student can go home at night. The family collaboration starts when a patient or student is in a residential program. Our treatment teams at our outpatient clinics will communicate with the residential staff in order to provide the smoothest transition. We welcome the families to come in to tour the clinics during that process, as well as we offer a parent support group, which is bi-monthly, that's located in each of our clinics, designed to support the families throughout the entire transition period.
Thank you so much, Matt. That was a great representation of IOP and PHP. My next question is for Dawn. So what would you say is the role in achieving long-term results within the IOP PHP model in a client's healing journey?
Yeah, absolutely. Thanks, Sabrina. So essentially what we're focused on is continued stabilization, but also healing. And so really what we're driving towards with PHP and IOP levels of care post-stabilization is how can we ensure that the individual doesn't return back to this dysregulated state. And so we're focused on really helping the individual to gain additional coping skills, helping them to be able to manage in the midst of crises. You know, we're not ignorant to say that crises are never going to come about. We're really helping the individual to better manage and to modulate themselves in the midst of a crisis, in the face of the crisis, but not just the individual themselves, but the family as well. So it's important to note that many of our kids during states of dysregulation or even suicide ideation, the entire familial system becomes dysregulated. So they're essentially under distress. And so what we're focusing on in our IOP and PH levels of care is really helping the individual to face those critical moments, but also help the family to become part of the safety net and create an environment where the child and the family themselves can heal, but also under moments of duress, they can face them together. So that's really the primary purpose of our level of care, is to ensure that they don't return back to the hospital. They don't return back to an RTC because they're under moments of duress again, but rather they can weather through those storms together in a supportive way. And that is essentially the essence of healing.
Dawn, thank you for that. I really appreciate especially you talking about the family system. And I know that Dr. Sims and Helene also had spoken about that in the short-term RTC model. So do you mind continuing to sort of elaborate on how we include the entire family system within the clinical approach in the IOP PHPs?
Right. So I'll start at Matt's mention of our MFG groups that we hold. Here we hold them twice per month at Embark Campbell. And really that is focused on the very foundation of let's reduce stigma. So we know at anyone's point in time throughout their life course, they could endure some pretty significant mental health issues. So we really want to help normalize that for our families so they can talk about it and get the children access to the care that they need. And then a secondary part of the MFG group is really to help reinforce some of our tenets that they've learned throughout their family therapy sessions here within the clinic, and do so together. So it's like a peer-to-peer group. And then with our family therapy that we have here, that takes place anywhere from 1 to 2 times per week. The family is integrated within the system of care. And really, we push the families to see that you're part of the continuum of care. So no one wants to see their child return to the hospital or to an RTC level of care. Therefore, in order to reduce the likelihood of that occurring, we really help the families to see that they are as much part of the solution as that they are part of the problem. So really helping to work with them to gain additional parental skills, helping them to identify and to see through psychology what it is that their kids are experiencing and how they can be part of that solution.
Wonderful. Thank you so much, Dawn, for elaborating more on how the family systems are incorporated into the IOP-PHP level of care. So now that you have, again, a little bit more insight perhaps on IOP-PHP, it is time for another poll. So moving right along. All right, are you ready? This is kind of a quiz poll. So we'll see if you were listening or if we talked about it. Otherwise, you will learn something. So I'm going to go ahead and launch the question now. So about how long is Embark's IOP program? 10 weeks, 12 weeks, or 15 weeks? All right, I'll give you like 2 more seconds. And we might not have even covered this, so you'll learn something. So I'm ending the poll. I'm going to share the results. So it looks like 65% said 12 weeks, and the correct answer is 15 weeks. However, it can change a little bit, but we do try to be transparent with families at the get-go. Lori, did you say 15 weeks? I see your, okay, all right. Star student here. Okay, and I'm going to launch one other question as it pertains to PHP. So about how long is Embark's PHP program? Oh my gosh, I am seeing the winner. Like this is a no-brainer. All of you are getting this one. All right, I'm going to go ahead and end the poll. 87% of you all correctly guessed or knew, you didn't even guess, it's 6 weeks. So there you go. Awesome job, everyone. All A+. Okay. So coming back to the panel, really, and really kind of the sense of urgency. So industry advocates have urged that states should really consider amending existing legislation to promote evidence-based practices in these programs. And so, Helene, if you don't mind answering this question from a clinical perspective, what is it that we do within our Embark programs as it pertains to evidence-based treatment modalities?
So this is sort of like a twofold answer for me. I think first and foremost, I always like to stress our Embark treatment approach, which is kind of the foundation and the structure in which we do the evidence-based care, if that makes sense. So we focus and we look at the family and the students through a developmental lens. We're looking and focusing on outcomes. We take a systems approach to the work we do with the family. So it's a family system approach. It's not just we're going to work with the kid and forget about the family. It's all fully integrated. And then we're highly experiential in the way we do the care that we provide. So we try to create situations and experiences for the students and the families that bring the concepts of the evidence-based work to life and help them really integrate it and take it back home with them. In terms of the actual evidence-based programming that we utilize, we have a 3-pronged foundation. It's dialectical behavior therapy, trauma-focused CBT, and we integrate smart recovery principles as well.
Thank you so much, Helene. And Dr. Sims, from a medication management lens, what does that look like within our programs?
Okay. With medication management, I'm a strong believer is medications can't do everything. And so in society, a lot of people just want the quick fix, and the quick fix is not going to continue to give you long-term stabilization. So it's key that the therapeutic process and the medication issue kind of work together and treat the whole individual, because we don't want to set a standard of quick fixes. So in doing that, it involves the whole shebang, so to speak. So in the beginning, we collect information. We review the documents. We interview the kid. We interview the parents. I love to have a full timeline history of the key understandings of the kid's journey to get to us. In addition to that timeline, you get family history, social history, past psychiatric history, and then medication history. Medication is history because you don't want to be the psychiatrist that recommends something that has been out there before and he failed, or he or she failed or got worse. So the history and information collection is key because that's going to set the standard of where you're going to go from there in working with the therapist that you have, as well as working with the family. Then with that, you kind of combine the information with the observations that you have. The benefit of short-term treatment and med management is that it allows for the adjusting of the medications to be more fine-tuned than in an outpatient basis, because the clinical team, including myself, the psychiatrist, can be readily involved 24/7. We can experience firsthand what families are experiencing at home or at school environments, and it gives me a hands-on approach to be able to kind of target the symptomatology that's caused the individual to have such difficulty. So in pulling all that information, it allows us to translate what we observe and what we may represent clinical symptoms and how to augment stabilization chemically. So with close observations and interactions with our kids from the clinical and the residential staff, allows immediate feedback to the physician to make adjustments. I'm strong on, of course, using FDA-approved medications. We get a lot of questions on doing things that are outside our scope of practice, but it's being consistent and making sure that we have to stay in our scope of practice of what we can prescribe. The key to success is the team players work together for the common goal, and of course, not thinking that one part of the treatment is better than the other. It's important to have the communication about the medications with your residency staff, with your clinical team, so that they have an educational of what you're trying to do on your end and what you're looking for. And so then we have an understanding of what they're looking for with regards to what they're seeing on the therapeutic side. When parents ask, what's your view about medication, I really want to set the standard for what I stand for, and I hope what Embark stands for is that it's the whole package. I always describe this situation: if you're in a hole and you're trying to get out, you're trying to climb, and you're grabbing hands to try to pull you out, but you keep sliding in that hole. The medicine represents a rock in that hole, okay? The rock may be something to stand on to where that individual can breathe, but it's not enough to get you out of the hole, okay? So the other pieces, your therapist, your pastor, your parents, your teachers, those are now you got a little bit more strength, okay, to hold on and apply those things that they're bringing to your life to help pull you out the rest of the way. So I use that analogy so we can see the whole thing, okay, and that how everything works together with understanding both sides of treatment rather than one thinking one's going to solve the problem. Because by the time they've gotten to us, they've tried a lot of modalities. So the key thing is fine-tuning it and finding what the key issues are and working together to kind of get to the common goal of stability.
Thank you, Dr. Sims. I loved that analogy. I've never heard it spoken like that. And Kellyanne, I'm looking at you and I'm like, you and I we were nodding our heads in that. I could see we were aligned. Thank you, Dr. Sims. That was great. So as you can see, I tend to be very upbeat and try to keep things light. But I'm going to transition because many of you might be here because of some of what is going on in the media as it relates to some short-term residential treatment centers. And so, while there are many that provide really excellent care, according to the U.S. Government Accountability Office, the GAO, they have reported that others have actually caused a lot of harm, even death, to a child. And additional studies have found, negligent short-term residential treatment programs that dramatically demonstrate ineffective management practices, lack of staff training, misuse of physical restraints, deceptive marketing practices. And so I really want to set the record straight and be able to speak to these issues head on, because it might be something that you are thinking about especially as it pertains to referring a client or even putting your child or recommending that a loved one, join one of Embark's programs. So, Helene, do you mind taking this one on and really helping us understand Embark's approach to excellent care?
So I think as you were talking and kind of highlighting what could be some negative images of residential care, the word that really jumped out at me immediately in my brain was transparency. We are fully transparent with the families and our students from day one. We keep an open line of communication and will always involve the parents every step of the way with anything and any interventions that we have planned and integrate into the process of healing with the student and family. So for me, it's really about transparency. I mean, we obviously do the things that are necessary. Our staff is fully trained. We have weekly treatment teams. We have daily huddles. We're always talking about every individual student daily and involving the parents and caretakers in that process along the way. And that's I find our key to quality as well as our key to safety, and really having everybody who is involved in the child's care be involved in the process very openly and honestly along the journey.
Thank you so much, Helene. I think transparency is quite an impactful word as well. And the fact that we do involve the parents and the clients in the feedback process along the way. So Dawn, if you would be available to answer and maybe elaborate on what that process of getting feedback looks like in real time and how we then use that data to have in the moment impact with our clients.
Absolutely. So I think a lot of programs measure success in healing simply based off of anecdotal data or some very superficial quantitative data, like, return to rehospitalizations, are looking at their trajectory of care. Yes, we use that, but more specifically and more scientifically, we use our outcome survey data. So from the very start of treatment, we're asking our kiddos and their families as well to first give us a temperature gauge on where the child is with respect to their symptomatology, where the family is seeing the child is, where they maybe see the entire family system, and how receptive are they to care. So once we gather that data, we are consistently measuring the child throughout the course of their care in addition to the family. Really, again, it's about our thermometer, so we can remove the mystery or the hocus pocus per se from therapy. Really, now we're able to scientifically measure, are we doing what we should be doing for the best level of care for this child? Are they responding to the care? And more importantly, are they healing? And one thing that sets us apart from most other organizations who may also be using the same outcome tools or survey data is that we're using matched sets, meaning that the individual, when they first input that data and we're first gathering it, it's the same rating from that same individual that we are publishing when we've gathered enough of the data for it to be published. So it's not a mixed data set. So whatever patient A came in, when they discharge, that's the same data we've gathered from patient A. Same with patient B. Patient B, it's a matched sets data as opposed to mixed sets.
Thank you so much, Dawn. That was a really great overview of the outcomes and how we do it and how we're intentional about it. So I am keeping track of time, and we have 2 minutes until 45 to the hour, or I guess 15 to the hour. And so I'm thinking I'm going to pause here and launch our last poll. So again, final quiz of the day. No need to be anxious. But this one is actually a little bit of a what you perhaps learned. Circling back on the full conversation about this continuum. So what is true regarding the supportive services at Embark? And this is a multiple choice question. So I'll give you a couple of more seconds because I know that there's a lot to read. I feel like somebody needs to have some interlude music. All right. 3, 2, 1. It looks like you are all A students. So 89% of you guessed right, and it might have been a little wacky because it was multiple choice, but there was just one answer. So all of the above are true. So I'm sharing the results. Scott, woo! Yes, I love that you're celebrating. I could see you from the corner of my eye. You were so ecstatic. All right. So again, thank you so much, Helene, Dr. Sims, Matthew, John, for being just incredible panelists and sharing your expertise and more about the work that we do at Embark as it pertains to IOP, PHP, short-term residential, and the rest of the continuum that we offer. And now we are going to turn the time over to you, our lovely guests. And so I have seen the chat just like pinging. Alex, since I know you're managing and monitoring the chat, do you want to go ahead and maybe ask a couple of questions from there, and then we'll see if anybody wants to ask any verbally?
Yeah. So I've written some of our questions down that have been in the chat. And definitely if one of your questions doesn't get answered, feel free to re-put it in the chat and we can try to get to it. So the first question that someone asked that I think is important, what's the difference between a PHP and a therapeutic day school?
So if anyone wants to answer that from the panel, feel free to jump right in.
Yeah, so I can take that on. So a therapeutic day school, their primary focus is on academics. And so they're arranging their curriculum around academics versus PHP. Our primary focus is on stabilization and therapeutic treatment. And then we will, of course, provide an academic hour or set time where we're helping the individual really to approach their academics and providing that therapeutic support along the way. But our primary focus is on the therapeutic stabilization of the youth.
Thank you, Dawn. That was awesome. So second question, do we ever refer up to a higher level of care to long-term residential or longer-term programs? And how do we decide where to send those students that we refer?
I can answer that. So within the continuum of care, we will address the students' needs where they're at. So a lot of times we get referrals for students where the family's really unsure. They're unfamiliar and uneducated about the system as it exists. So they'll make a referral and I just need to see a psychiatrist, or my child needs individual therapy. We can invite the child into the clinic, work with the family, and engage them in a level of care that is as least restrictive as possible while still maintaining the student safety. As the child progresses, if we see the need for a higher level of care, we will move students through the curriculum, through the continuum as needed, just based on the response that we see. Sometimes we can see very early on that the student may need a higher level of care, but the family is resistant or reluctant to make that decision. As long as we feel that we can safely program the student in like a PHP or an IOP, we will do so. And then during that time, the family can then see that, okay, maybe they were right in their initial assessment, and that, maybe my child does need to go to an RTC. But at this point, they've already established therapeutic relationships with the clinical team. So it makes them more open to accept therapeutic recommendations.
Great, thank you so much.
Can I add something here, Alex? Is that okay?
Yes.
We also have great relationships with ed consultants all across the country. And so we refer a lot out to ed consultants who are great at finding different levels of care and that are really familiar with programs all around the country. So we have great relationships that we utilize them for as well.
Thanks so much, Rachel. That's a great point. Similar to the earlier question about a therapeutic day school, what is the difference between a crisis stabilization center and an IOP or PHP program?
I can answer that, unless you want to, Dawn. Go ahead.
No, let's tag team it, Matt.
Yeah, crisis centers are responses to immediate needs. Should a child be at home, talking about how, suicidal ideation with a plan, it's an emergent reaction to a situation. We often get referrals from local crisis centers where they'll spend time working with a psychiatrist, they'll get a comprehensive evaluation. The psychiatrist might determine, okay, this child does not need an acute level of care, but does need a more structured-based therapy, and we will get a referral then. We have psychiatric staff consisting of psychologists and nurse practitioners that provide additional support for the child while they're in treatment. Should they express a higher level of suicidal ideation, we can evaluate them almost immediately and refer them to the appropriate course of treatment.
And just to dovetail off of that, is that really a crisis stabilization unit, their primary focus is on ensuring that the child does not leave the center and harm themselves. So really their primary focus is on stabilization, whereas in our level of care, PHP and IOP, yes, stabilization remains the focus, but in addition, we're helping to and working towards healing and increasing their coping skills.
Thank you so much, Dawn. I know Alex still has a ton of questions in the chat, but I figured for a little different vibe and energy, does anybody want to unmute themselves and ask their question?
I'll ask a quick question. So I'm Lauren D. Simone, and I was wondering, I know it varies probably by program to program, but is one of the insurances that you guys take TRICARE?
Lori, do you want to answer that question?
I can help with that. I was unmuting Sabrina. No, we are not contracted with TRICARE, nor are we certified because it takes both certification and a contract.
Okay, so you guys don't do single case agreements with them or anything?
No, because we are not, our individual programs are not certified. We have not gone through the certification process with them.
Got you. Thank you.
Thanks, Lauren. Great question. And thanks for being open to unmuting yourself. Anybody else want to take the plunge? Ask a question.
I'll ask the question.
Go for it.
One of the, I saw that you treat anxiety and depression and all of those. And one of the things I'm certainly seeing more and more of is late diagnosis autism. And that is usually discovered through a neuropsych with a particularly enlightened neuropsychologist, whoever that may be, after the child has struggled for a while with anxiety and depression. So I'm wondering what resources you have for late diagnosis spectrum patients and parent support groups.
I mean, I'll speak to it at the residential, from the residential side. We don't have psychologists on staff, but what we'll do through that treatment team process and through observation, working with family and the student, is if we are suspecting that perhaps an autism diagnosis is looking like it may be likely, we will work with the family to coordinate getting the necessary assessments and diagnostic tools in place for them to kind of continue. We may not, because of our short-term nature, necessarily be able to fully diagnose and come to that determination while they're in our care, but we'll work with the families on connecting them to the resources after they leave.
Actually, also at the Embark at the Forge, we've had actually several of those situations where we've had teens come in and the ASD diagnosis has been missed. We have a psychologist that's in the area that's contracted to us, and she comes upon request to do testing. So there's some that when I'm suspicious of that diagnosis and we haven't had it solidified by psychological testing, we'll contact her and she'll come and actually do a full testing battery to see if we can solidify that diagnosis. Upon doing that, depending on what behaviors and symptomatology that we're dealing with, because in this environment, ASD clients can really struggle because of the social stimulation. Some do fine, but some struggle. So it all kind of depends where they are on that spectrum, of course. As far as my input, I will try to introduce medications to try to stabilize that as far as the anxiety and the behaviorals that some of that stimulation creates. Therapy-wise, we may incorporate some social situations to kind of help with the process while we have them in our facility. And then in addition to that, we, from day one, once we're suspicious and we've got some confirmation from our psychologist, we'll tend to look in the area of where the individual lives and contact the insurance company to see if there's any places in their area that provide services for spectrum disorder individuals. And then try to have them placed in those situations so we can have some form of continuum of care related to their diagnosis.
Thank you so much. So we have about 4 minutes left. I'm thinking that we can get one question out of the chat and then maybe one more person who might want to say their question by voice. I also noticed in the chat there were some questions regarding resource needs. And so in these last 4 minutes, all of the directors of professional relations across the country are going to be putting their direct contact information in the chat. So if you didn't get your question answered and if you have a specific resource need, please, please, please utilize us. That's what we're here for, is to help triage and help navigate resources in the community, even outside of Embark. Our goal is really to help support our communities, and we do that together. So keep an eye out on the chat. And then if one more person maybe wants to ask a verbal question, I'll leave a little bit for that. Any takers?
I did just want to address really quickly, there was a question about affordability and having access to other programs. I would encourage you all, that's what the Director of Professional Relations role really is meant to be. So if you have clients in your area and Embark is not accessible to them, we would love to chat with you about other options. We are always networking and connecting with other programs as well. And really our goal is to kind of all come together and support the people that we want to support. And so I encourage everyone, if you are having trouble finding resources, really rely on the Directors of Professional Relations. We're here to help.
Thank you, Alex. Do you want to maybe pull one last question from the chat and then we'll use that to close us out?
Yeah, so there was in the middle of us chatting, a little confusion about family programming in both residential and IOP PHP. Could someone just touch again really briefly on the importance of treating the family in our programming and how we bring the families in with our students?
Sure, I can discuss that. So the family therapy component is an essential and it's a requirement for every level of care. In the PHP program, family therapy is 1 hour a week minimum. In the IOP program, we do family therapy about once a week, once every biweekly, but it is a requirement of the program. In addition to that, we have our multi-family parent support group that is held We do it twice a month. Most clinics do follow the same structure. The multifamily group, parent support group, is open to anybody. It doesn't necessarily need to be an Embark family. It can be anybody in the community that's interested in learning and connecting with other families who are currently struggling with adolescent and young adult teen anxiety and depression. So it is an essential component of our program. The therapists have direct contact with the families daily, and they're actively involved with every aspect of their treatment. We find that welcoming them into the clinics and into every stage of the program is a huge thing. Just imagining them being on a first name basis with all the clinical staff and the staff throughout the building, it really helps create that warm environment that we're looking for.
Thank you, Matt. Right on the bell. So we are at 1:00 Eastern time, and I just wanted to again say thank you so much to the panelists. Thank you so much to all of our guests, all of the Embark staff members who are here. Just an incredible spirit and energy, like knowing that we are all here together, making a difference, doing good for our communities. I just really hope that you take that in. This last breath of this virtual panel, you are all so important. And again, just want to say thank you for being here and hope you all enjoy the rest of your day. See you later.